Welcome everyone. My name is Megan Brotherton from the Australian Safe Communities Foundation, and along with Barbara Manuso from the Victorian Safe Communities Network, we're your hosts for this webinar. Before we start, just a couple of housekeeping matters. We have two great presenters today who will have around 30 minutes each for their presentations. We hope to also have time for a couple of questions. Each participant has access to the GoToWebinar control panel on your screen, which is on the picture now. Please familiarise yourself with its features. If you're having any problems, please send a message to the organiser via the control panel and we'll endeavour to resolve the issue. If you'd like to ask a question of our presenters, please type your question into the question area on the control panel, or if you have a microphone that you can use at the end of the session, you can put your hand up, which is the little yellow hand there, and you'll be able to ask your question. If your question isn't answered, the presenters will provide an email address at the end of their session for you to correspond with them personally. The webinar will be recorded and available for viewing next week. I'll now hand over to Barbara to introduce our first speaker.
Thank you, Megan, and welcome everyone, and thank you for making such an effort to join us. Looking at the list of participants, we have people from around the world joining our seminar today. Thank you again. As you would have noticed from the invitation, today we're privileged to have with us two amazing presenters that will share their wisdom and knowledge around their work in making our community a safer place. Firstly, we have Dr. Villavasas, who is currently working in violence and injury prevention at the World Bank. He has 20 years of experience working on intentional and unintentional injury prevention in international health. One of the things I did want to share about Dr. Andres Villavasas is that when he worked as medical officer at the Department of Injuries and Violence Prevention at the WHO in Geneva, Switzerland, he developed and co-authored the TEACH VIP Injury Prevention Curriculum and several WHO policy documents on violence prevention. Some of you might be very familiar with this great resource because we've published it in our newsletter. If you have not as yet, I highly recommend visiting and accessing it on the WHO website. Over to you, Dr. Villavasas. Thank you.
Well, thank you very much, Barbara. I really appreciate this invitation and opportunity to present. I will be talking for about 20 minutes approximately, and then there's some space for questions. And this talk is going to be mostly on the issue of violence, but how violence, when it's occurring early in life, is related to all other forms of violence, and how that modulates the early exposure of violence, modulates later in life expressions of violence in different ways. During this presentation, I will talk a little bit about an overall framework of how we can understand the different, how different risk factors and protective factors interact, the environment, the person, and how these risk factors interact at different levels, types of responses that we can have to prevent or to address the issue of violence, either by modifying behavior, legal measures, or modifying the environment. I'm going to describe a little bit how we classify violence, but in addition to just talking about the typologies or that classification of violence, I'm going to mention a little bit how those different forms of violence relate to each other, how they affect people at different times in their lifespan. Then we're going to talk about those key risk factors that early in life are modulating a lot of the things that might happen later on. And we're going to finalize with some interventions that are very useful, proven effective for the prevention of violence against children mostly, but subsequently they have an effect on the prevention of violence at later stages. In the last section, we're going to talk a little bit about key elements that are important for the implementation of the different interventions that exist. To understand the framework, that perhaps a lot of you have seen what is called the socio-ecological model. It is very useful because it expands what, from the perspective of public health, we understand as the interaction between a person, the environment, and what we call an agent. In this case, the agent that produces an injury is a form of energy, that is expressed in a violent act, and that form of energy can come in many ways and affect produce bodily harm. Indeed, that's just a physical definition, but there are other, as we will see, there are obviously other forms of expressing violence that are not physical. That environment is a rich environment that we can understand as an environment in relation to the individual. That individual is embedded in a particular interpersonal world of relationships within the family, with friends, close acquaintances. And those families and acquaintances are within a particular community that has institutions and different types of organizations, which are all embedded in a particular society and type of culture that has certain norms and certain ways of acting. So all of the types of interventions that we're going to talk about are interrelated and have an effect at each one or many of these different levels. And these levels are very much related. So when we think about prevention and we think about problems, we can think about how different risk factors or protective factors might be expressed at the different levels that I have just mentioned. In terms of the types of responses that we have available, we have behavioral responses, which are basically strategies aimed at modifying, in the case of children's behavior specifically, or they might be directed at parental or caretaker behaviors in a very proximal way. So this is just to give you an example. Many behavioral issues can be applied to entire communities or institutions like schools, etc. But one way of understanding preventative interventions are interventions that are aimed at changing behavior. Another tool that we have is legal measures, the law. Through the law, we can modify or create a particular framework that is directed towards preventing or avoiding that different forms of violence that might occur. We might have legal measures against corporal punishment, a wide variety of child protection laws. We might have laws that protect access against means, for example, alcohol or drugs or firearms, all in relation to children. Of course, there's a wider level of legal measures that we can implement, but this is yet another tool that we can use for responses to violence. And then we can modify the environment. And the environment, we can understand it as the social environment or the physical environment. So we have different types of interventions that can be aimed at organizing communities, at increasing the social cohesion between communities, or interventions that are aimed at changing the social environment at the level of institutions, for example, in schools or other institutions. So this type of modifications of the environment are occurring at a wider level and are in some cases affecting only kids, but usually, typically, the modifications of the environment are going to be aimed at the community in general and at the entire population. And then, of course, we have physical modifications of the environment, which are aimed at creating safe physical places. There are many characteristics that can be associated to an increased likelihood of the occurrence of violence in a particular physical environment. So we aim to design it or modify it in a way that we avoid that probability of violence increasing. So in general, we have all these tools, and we can use a wide variety or a combination of these in the different interventions that we apply for violence prevention. The WHO has created this table that you see, which is called the typologies of violence. It basically attempts to classify violence in its different expressions, and in terms of how it is shown either towards the individual who exerts the violence when it's self-directed and expressed as suicidal behavioral self-abuse, what we call interpersonal violence that can be expressed in the family or in the community as a child against an intimate partner, against an older person, in the community between acquaintances or between strangers. And we also talk about collective violence, which is related more to what we call commonly known as war or conflicts of that nature that can be of social, political, economic reasons. And those forms of violence can be expressed in a physical way, in a sexual way, some of them, in a psychological way, or through deprivation and neglect. But this typology is somewhat artificial because in reality we see that a person who might be participating in one form of violence might also be participating in another one. In the case of war, we see people committing acts of violence in the context of a particular conflict, but at the same time, they can be committing interpersonal violence acts or violence against the family, etc. So the separation is somewhat artificial, and it's important that we understand that, because when we do interventions, we're going to have an effect at multiple levels, and those interventions are going to affect the different expressions of violence. It helps us explain some risk factors. It helps us understand some patterns that are inherent to some of the types that we define here, but I really want you to understand that this is more of a continuum, and it is expressed in different ways. And to see it more as a continuum, we can see it throughout the lifespan. As in the bottom part, you can see the different categories of or stages of life from early childhood to adulthood, and you can see that you can experience emotional, psychological violence and witness violence throughout your entire life, or experience sexual violence, child maltreatment indeed in the early ages, bullying, persons can experience bullying, children at later stages in the school, certainly in middle childhood and adolescent, but even adults can experience bullying in the workplace, and so these expressions manifest themselves throughout the lifespan. Youth violence, of course, occurs either in the school or in the community. It indeed affects the majority of people who are affected by violence, either as perpetrators or victims, are within this age group. And then intimate partner violence. Here are some examples. Of course, if I add here a particular expression of violence manifested through war, then it would be pretty much the same as witnessing or experiencing violence throughout your entire lifespan. So they are very much interrelated, and they occur, or they can coexist and co-occur, these different manifestations throughout the lifespan of a particular individual or a family nucleus or a community or a particular society. So when we talk about prevention, we really want to think about prevention from the very early stages of life. And by very early stages, we talk about the prenatal exposures. There are things that we can do at the prenatal level. We know, evidence tells us that unwanted pregnancies are actually associated to neglect, child abuse, abandonment, etc. And these risk factors and these early exposures of violence affect individuals later on, as I'll show you in a few minutes. So lack of access to family planning might be an important condition that actually can foster or can contribute in an indirect way to the occurrence of violence because it allows for unwanted pregnancies to occur. Maternal stress during pregnancy, for example, through exposures to abuse or other societal and community stressors can affect later on not only the pregnancy and the outcome of the pregnancy, but later on in early stages the development of the child, and of course maternal exposures to substances, the presence of alcohol and drugs in the home, either and that consumption can certainly produce considerable alterations, physical and psychological alterations and addiction in the child once the child is born, and that is associated also with different forms or expressions of neglect in the home. But there is evidence, and we know that toxic stress damages the body, actually physically damages the body and the brain. The violence against children and in youth increases and changes the the hormonal environment of the body and the brain. And it changes the architecture and the development of the brain during childhood and during the period of youth. The brain is undergoing a considerable development of and connections of the neurons. This toxic stress or this chronic exposure to abuse alters the way those neurons connect, and it can be physically demonstrated, and that alters subsequently changes behaviors and the conditions of the brain, and can be associated to mental and physical health problems, and even premature aging that will affect individuals later on. Why premature aging? That seems kind of strange, but there's some studies here. I'm showing you one abstract of a study that found that childhood maltreatment is associated with shortening of the telomeres, and the telomeres are the tips of the chromosome. In the tips of the chromosome, we have a series those are called the telomeres, and they contain DNA, and the telomeres usually protect the cell from aging and protect it from a series of conditions such as cancer. The chronic stress, what it does is it actually reduces the length of this telomeres, and so in reducing it, it actually facilitates or reduces the lifespan of the cell. So it's associated with cellular aging, and so it actually produces at a very, very deep level in our bodies some measurable changes. Another article that shows pretty much the same is associated with telomere shortening, and that particular shortening that is observed early on can actually cumulatively over the lifespan have a potential impact on the longevity of that person or the conditions or the diseases that that person might get later in their life. But independent of that particular association that is very physical, we see that violence can also be related to a lot of conditions. It's related to non-communicable diseases in many ways. It's related to communicable diseases that can increase the risk of fetal death, of sexually transmitted diseases, of pregnancy complications, of HIV, of the consumption of alcohol and drugs. It can also be related to a series of mental health problems, and it's indeed related to other forms of injuries, as you can see. So violence against children is an expression or a particular phenomenon that actually has very, very direct and indirect consequences for health in many, many ways. To give you a very specific example, the path leading from violence against children to HIV. An exposure of violence against children facilitates the direct transmission of the virus, either because of a sexual act, in a violent sexual act, for example, but an exposure to child abuse can hamper or compromise the negotiation skills of the mother and contribute to the transmission of HIV. It can force children out of the homes and increase the risk that they might be exposed to prostitution, trafficking, and HIV, or that particular exposure to abuse and violence can increase risky behaviors that might lead to HIV. So there are very concrete, this is just to show you one of the particular examples of how violence against children can affect other conditions. I mentioned early on the brain, and here's an example of two brains. The one on the left is a cross-section of the brain of a child that is growing up in a stable family. And the one on the right is a cross-section of a brain of a child who grew up in an institution and who was subjected to a considerable amount of abuse. You can see that in the brain scans, the type of activity expressed in the form of colors is very different. So the activity and the connections that the brain has developed at the same age are very different, and there's a lot of compromise. There are less connections in some cases, and larger spaces, empty spaces in the brain of a person who has been abused. So there are very, very direct, measurable, observable, physical and physiological changes that are going to affect later on the behavior of individuals. Indeed, all of these changes that I'm showing you that are physical are not the only ones. We have a lot, as mentioned before, a lot of additional elements that are important that relate to exposures to abuse at the family level or at the community level or at the societal level. And these expressions can occur, for example, in the school as bullying, or in the house as direct abuse, or in the community as witnessing violence when you live in a neighborhood that is severely affected by violence and that is witnessed by kids, or in a society that allows certain or has certain levels of violence where everyone is exposed to that. So what can we do about it? Well, we can do a lot of things, fortunately, and the good thing is that the earlier we intervene, the earlier we are going to be affecting the development of those brains and those kids in a positive way, and educating them, not only changing the physical conditions of their brains and their internal biological environment, but also their cultural, their social environment. We're also going to modify it early on. So interventions at the individual level are usually aimed at education and life skills for children and parents. We teach parents parenting strategies, behavioral strategies for children, and these parenting strategies have been shown to be considerably effective for a very, very long time. At the family level, providing parental and caregiver support, reducing a series of stressors, helping parents address issues of substance abuse, modifying that family environment has also been shown to be extremely effective. And those types of interventions have effects that can last for decades and can, when applied to particular families that have certain conditions of risk, they are actually have been associated with less likelihood of occurrence of violence later on in life. At the community level, we can do a lot of things in terms of strengthening income or strengthening the economic sort of environment of particular families or entire neighborhoods, the creation of safe environments, or strengthening response services to violent events. And then at the societal level, we can change norms and values, or we can act and implement and enforce legislation. So you see that the different forms, the behavioral, the environmental, and the legal strategies that I had mentioned at the beginning are actually being manifested here at the different levels. More in depth at the individual level, we have, for example, increased enrollment in preschool, primary, and secondary schools, establishment of safe and enabling school environments, improving children's knowledge about sexual abuse and how to protect themselves against it. We can also have interventions that are aimed at changing life and social training on life and social skills, or addressing later on in life adolescent intimate partner violence, and have programs that are specifically aimed towards that. At the family level, in terms of parental and caregiver support, home visits are incredibly important. They have been demonstrated in many places to be considerably effective and have an effect that is very long-lasting and very positive in families. Those interventions can also be at the family level, can be delivered in groups or in community settings, or different caregiver and parental support through a combination of programs that merge or combine school, family, and community, and address different risk factors or different situations and provide support to parents at all levels. At the community level, we have mentioned strengthening of income, addressing employment. There are interventions that are looking at cash transfers to families, to mothers, for example. Group saving and loans combined with gender equity training has been shown to improve the environment of the family and contribute to a more pro-social type of environment in the family, thus reducing the likelihood of abuse. microfinance strategies combined with gender norm training. All these strategies are intended to provide a more solid income and support, and usually the gender component is very important because the mother's role is very important in stabilizing these family environments and providing a more sustained support, allowing for kids to go to school and to be educated in a better way. Creation of safe environments. So we can look at addressing hotspots of violence and have actions that are very much directed at those hotspots that are geographically and temporally located in different places, usually in urban settings. And so we can, by studying those hotspots, we can actually engage in either preventative or control interventions with enforcement or with modifications of the community environment. Interrupting the spread of violence. There's a program, or there are programs that look at engaging particular persons who are more likely to be engaged in violence and trying to interrupt those moments or those situations that might escalate and lead to violence. So community members participate as diffusers. They tend to diffuse these types of events, and thus they interrupt acts of violence that, because of a particular impulsive type of behavior, could be lethal or could lead to a particular injury. The purpose of these community members is to interrupt precisely that escalation. We can also improve the built environment, address abandoned areas. There are interventions that improve the light of the community and are associated with less crime, creating safe environments for walking to school for kids, are different modifications of the physical environment, facilitating, for example, reducing the density of alcohol outlets in particular areas. That is associated, a higher density of alcohol outlets is associated with more violence. So there is a series of environmental, physical environment interventions that we can apply, but those of course apply to entire communities. Strengthening response services, we have counseling and therapeutic approaches, screening combined with interventions, treatment programs for juvenile offenders in the criminal justice system, and foster care interventions with welfare services. And then at the societal level, we can change norms and values by changing adherence to restrictive and harmful gender or social norms, for example, community mobilization programs, bystander interventions that address either gender violence or community violence, and then all the package of legislation that we have, either banning violent punishment of children, criminalizing sexual abuse and exploitation of children, limiting access to and misuse of alcohol, and limiting access to firearms and other weapons. And this all needs to happen in a particular community, but some of these interventions can happen in the home, some can happen in the school, in communities, or in all of them. We usually can involve the family or different institutions, health services, the community, and different government sectors. There's a role for different government sectors. Transport has a role, the police has a role, health has a role, and many sectors in the government have a role in preventing violence. What is needed? Well, we need information, obviously. We need good information to understand the magnitude and the distribution of violence. Who is it affecting? We need capacity. Capacity building is really important. Usually the problems of violence are manifested in urban settings and they're local. And so when we target and we look at interventions that are aimed at municipalities, we have to have municipalities that are collecting good information, but that have good capacity also within them to utilize that information and interpret it in appropriate ways. That requires some local coordination, and interventions indeed require some local adaptation given the differences that we have in societies. And that type of information collection can facilitate monitoring and evaluation of interventions, and as well as once we get answers or we change the risks or the occurrence of violence in a place, then we can use that for disseminating information and promoting particular practices. With that, I have spoken of a very, very large topic in a very short time. I will stop here, and if you have any questions, I'll be very happy to answer them. Thank you very much.
Thank you, Andres. We do actually have one question, but looking at the question, I'm not sure whether you're going to be able to answer it because it's a local question. But the question is around a video that is used in Victoria called The Mask We Live In, and they have purchased a license for it, and they're wanting to know about what age is the best to use it and what age is too young. So, Barbara, I'm not sure whether you can answer that question.
No, I cannot answer that question immediately, but I will definitely look into it and come back to the person that asked the question, because for sure, I'm sure that we would be able to find out exactly that.
And a second question from police, which is, what do you see as the role of police in interventions to prevent youth violence?
Well, that's a very good question. Police has several roles. You can think of police as a institution that enforces legislation, that does control, but you can also think of police as a particular institution that can engage communities in a proactive way, such as in community policing, and work to actually create environments that prevent the occurrence of violence, that increase the communication between police and communities, that modify the physical and the social environment, that create a better sense of connection and understanding between the community and the police. And so the police has a role that is really important, both in prevention but also in control. The type of repressive actions of police are typically not recommended because they backfire, and of course the police has to do some type of enforcement, but if that is attached to particular interventions that are aimed at controlling or de-escalating or at preventing violence, then that is a much better informed type of police activity. Police also are really important in collecting information that is relevant to understand violence, and the depiction or the knowledge or the mapping of violent events in time and in space is typically an activity that can be done by police or police and health, as it's done in some places. And so diagnosing and understanding the magnitude of the different expressions of violence and other forms of crime is really important for planning purposes. So it has multiple roles that need to be executed in coordination with other types of sectors within a particular community.
Okay, and we have one more, Andres, which is, have you done research to correlate to results of anti-bullying programs in communities and schools that have shown success in reducing bullying and violence? If so, what methods or messages have been successful?
I personally have not done research on that. I do know that there are some anti-bullying programs that are effective. I think either direct bullying or cyberbullying are some things that are becoming very common, that can actually lead to disastrous outcomes, as we've seen in the news in many places. There are multiple programs, and I'd be happy to get you either about concretely evaluated ones and their interventions. They don't come up to mind now, but I do know that they are applied in school settings or other types of institutions, and they are indeed effective.
Thanks. If you could get that to us, we'll be able to then share with everyone, all of the attendees. So we'll leave questions there. Thank you very much for the presentation. As we said, it's recorded. People will be able to contact you directly if they have any other questions or come via the organisers. So thank you again for your time today. So now
a pleasure to be here, and thank you very much for this opportunity.
Thanks. So Barbara, would you like to intro the next presenter?
Thank you again, Megan. Yes, so Dr. Bangdiwala unfortunately couldn't be with us in person, but we have pre-recorded his presentation. Of course, you're welcome to email questions to him. So just a little about Dr. Bangdiwala. He's a full professor of biostatistics at the University of North Carolina at Chapel Hill and a senior statistician at the UNC Injury Prevention Research Center. Thank you, Megan.
WHO initiative. This is a global effort for grassroots-driven interventions at the community level to increase safety. The research questions that one may ask is, how do we know that participation in the network works? Or how does a community know what programs work? The contents of the webinar today will be several. We'll be talking about the importance of evaluating efforts. What to evaluate, we'll talk a little bit about process, impact, and outcome evaluations, a little bit on methodology, on research designs, qualitative and quantitative information, and indicators, and then we'll illustrate this with a proposed way of evaluating the WHO Safe Community Model. So the main purposes of evaluation are to help us decide whether an ongoing program works relative to its goals and objectives, maybe also look at why the program did or did not work relative to planned process, helps us decide also how to restructure the program to make it work or work better, and whether to change future funding for the program. For a particular community, it actually is very helpful to show folks in the community that we are doing good things, show stakeholders that we are doing good things, and also gain a lot of political clout. So why is it valuable to communities? It's helping them to choose priorities, to recognize their successes, maybe learn from their failures, and especially how to save scarce resources and improve the quality of the programs. All of these actions will help us in the sustainability of a particular program. Now the evaluation, when we talk about evaluation, we need to think about a continuous cycle where we may identify a problem and where we're working. We define a target audience. We then identify resources, set goals and objectives, choose strategies. We review those strategies and refine the implementation in what's called formative evaluation. We implement those strategies, and then we go to what's called the formal evaluation aspects of process, impact, and an outcome. We disseminate our results, and we continue this process. It is not a single-time evaluation, but a continuous process. So I mentioned that there is formative evaluation, which is prior to implementation, and the formal types of evaluation that are done of a program involves process, impact, and outcome. And let me take a few seconds to talk about these particular types of evaluation. When we talk about process evaluation, we're trying to address what was done, how was it implemented, how well was it implemented, was it implemented as planned, and should it be done differently next time? So the types of questions that we are looking at in process evaluation is who carried it out, was this the appropriate person or group, who supported or opposed the intervention, what methods or activities were used, who participated, were participants involved in the planning, what resources were used, what problems were encountered in administering the intervention. Impact evaluation is now looking at some of the results. And here, the results may be in have changed people's knowledge or attitudes, beliefs, skills, or behaviors and practices. So in impact evaluation, the types of results and questions that we ask is, did the participants' knowledge, beliefs, and attitudes change? Or was a policy adopted? or was a policy enforced? Or did behaviors related to injury events change? And I give some examples of some particular types of situations where one would be asking these questions. So these sorts of evaluations of the results of the impact are looking at what we call precursors of the outcome evaluation. And the outcome evaluation is when we're looking at changes in injury events, for example, or in morbidity and mortality, or in the costs of the injuries, whether they're direct and indirect, or individual and societal. So the types of things that we're measuring in outcome evaluation is that the intervention reduced the number or rates in a defined population of events such as falls or traffic crashes, injuries, or deaths. So those are the three types of formal evaluation outcomes that we look at. So we talk about process, we talk about impact, and we talk about outcomes. How do we go about obtaining information is the next topic that I would like to cover in this webinar, addressing methodology. So parts of methodology, well, where do I get data and how can I successfully use it to produce meaningful answers? One needs to have an understanding of the data sources, how they define injuries, injured individuals or injury events, and how does one use and integrate data for studying injuries. The second part of methodology is how do we actually come up with ways of understanding risks of an event, or what are the study designs and what risk estimates they provide. Then we talk about statistical models for risks. And then finally, how do I know the effect of some action? This is where evaluation is what we're really doing. So how do we understand the effects, and then what study designs and what effects estimates they provide? As well, we go back to statistical models for risk. So let me start with some examples. Surveillance data is one of the very commonly used and obtainable type of information, and it allows us to study trends over time. I give an example here of a study that was done using surveillance data on the number of deaths of motorcyclists and how does that relate to interventions. And we see here that it's a simple graph where one is plotting over time the number of deaths, and one is identifying different types of activities that were done in the city, and one tries to argue that the changes that are observed in the number of deaths may or may not be related to those activities that were done in the community. It allows us to study descriptively trends over time, but many people argue, how do we really know if something is actually due to that intervention or maybe due to other factors that may be going on? But surveillance data is a very useful way of getting data to study the impact of our interventions in the community. Another example is to get targeted observations that allow us to do what's called a before-after study. This study that I'm illustrating here is from Sweden, where they were looking at the impact in terms, or actually the outcomes in terms of crashes and collisions that took place when they intervened in a particular bridge in Sweden, where there was initially, the first time, there were just 2 lanes, and cyclists and pedestrians were sharing the lanes, either coming or going. In the second period, the government had made a structural change where the cyclists were separate from the pedestrians, and they wanted to examine whether the effect of this intervention done on this bridge was revealed in terms of the crashes, single crashes and collisions. So they were looking at the period before the intervention and the period after the intervention, and what they noticed was actually that there was a higher rate of crashes and collisions afterwards than before. The reasons for this are some things that they did not measure and led to speculation. In order to be able to get an understanding of potential factors that may be affecting the rates before and after or the trends over time, one usually requires to collect data in what's called research studies. So the third way of getting information on factors that may be related to a particular type of intervention or to a particular type of injury would be to do a research study. So I illustrate here, I don't give the results of them, but one way of doing it that's not too expensive is to do what's called a case control study, where cases, in this example, they looked at fatal residential fires, so residential fires in which there was a fatality, and they took residential fires that then resulted in no fatalities as the controls. And then one looks at the factors that are present in the fatal ones and the factors to see if they're present or not, the non-fatal ones, to be in order to get some relationship on whether that factor is related or not to a residential fire being fatal or not. Those types of studies may tell you about the force of association, but they don't really tell you whether a factor is a causal factor on some injury or some outcome of interest. So what one really requires is what's called an experimental study, where one is controlling all the other factors and one randomizes groups or individuals to a particular type of intervention. This is an example that has recently appeared where they studied in England looking at implementing a fire prevention intervention in what's called a randomized control experiment or trial. They had to do it in clusters, and they actually have started this study. They have not shown the results, but this is the type of study that would allow us to study the impact of an intervention done in a community setting to see a causal relationship. Now, research studies are quite expensive. Communities are not able to normally do this. So how do we evaluate a particular community that's participating in the Safe Community project? We may have to rely on ongoing registries and surveillance data in order to do so, and looking at trends and before-after studies. Now, when we're doing that, we face unique issues in injury research. The studies here, when we're studying diseases, other diseases, we don't have the peculiarities that we have in injury research. In injury research, we have events that can be considered rare occurrences, where people are not exposed constantly to being an injury victim, because you have to be engaged in a particular activity in order to be at risk for getting injured. There's multidimensionality in the sense that one can have multiple types of events causing multiple types of injuries and multiple types of severities, multiple body parts. So that makes for complexity. There's many covariates or factors that can affect the results. We have events that can occur once you have a crash. You can still, if you haven't died, you're still driving, you can be involved in another crash. And we have competing risks. You may be injured from different mechanisms. Why I mention this is that these unique issues lead to complex relationships that make it difficult to understand risks and to evaluate effects. So given this, where does statistics help safety research? Statistics is a science that helps us understand the effects of variability and chance, and helps us, for example, determine how many events to study, how long to study a situation, how to obtain estimates of important parameters. So how many disabled persons in a particular place or in a particular year due to road traffic injuries. It also helps us to summarize quantifiable information. how to describe it, and how to build the evidence of what works. So the tools of statistics are probability theory, and I'm not going to go into that, but I mentioned to you that it helps us to estimate risks and to develop models of the probability distributions of the chance of things occurring. It focuses on associations using the probability models, and it uses mathematics, which is therefore something that I'm not going to go into here. But these help us understand the risks and effects. Why do we want to understand risks? Because it helps us alter our behavior to lower the burden on society. And we study the effects of that because we want to know the reasons why things are occurring. Reasons matter. As said here in this article, reasons for effects used alone without evidence of effectiveness are unreliable as predictors of the effects of a policy, but reasons matter anyway because they help us explain how. They depict the mechanism through which a policy produces effects. It's easy to find reasons, difficult to find the correct reasons. So we use statistical tools to try to, in observational data, when we're not able to do experimental studies, to try to understand the reasons for the effects of what we're observing. Now, what are the measures of effects that we can use? In these before-after studies, and the surveillance data studies, we look at several of these. Most of the time, we look at absolute numbers, counts of deaths, for example, as in the Kali study. Differences in occurrence rates at different time points in a before-after study, or ratios of occurrence of rates at different time points. We can look at trends over time, so we can look at absolute changes, or just differences, or we can look at relative changes, or, since there's multidimensionality of factors, we often do adjusted effects, so we do models that adjust or control for multiple factors. So let's go back now to our Safe Communities model, which is the purpose of this webinar. How do we go to illustrate how we go about doing evaluation studies? Many of you may know that the Safe Communities model is a comprehensive program for the safety of members of communities. But do we know if it is effective? We that participate in it may be convinced, but is the scientific community convinced? And members of the community, are they convinced that the Safe Communities model works? So the questions that we should be asking ourselves is, what research designs are possible to conduct a scientifically valid evaluation? What outcomes are the appropriate ones? And what are the biases in the choice of evaluation approach? So how do we evaluate it? The Safe Community itself has come up with what they call 7 indicators, and the 5th indicator is to assess the program's processes and the effects of change. So they're talking a bit about process evaluation, and the effects of change maybe implies on impacts and on outcome. But what do we evaluate? Do we evaluate each individual's safety promotion activity? Do we evaluate a community's entire program, or a country's safety profile, or even the whole movement of safe community in general? It also says that we should evaluate the programs usually address everybody in the community. So what group should we evaluate? Some programs are for young children, others for adults, others for the elderly, or many of them are for vulnerable groups. We should do everyone, but how can we do this? And how do we get the data? Who provides the data? Do we do sporadic surveys or studies? Do we do ongoing surveillance systems? So the classical approach would be to get the evidence of effectiveness from doing studies and obtain quantitative evidence that favors a hypothesis that the intervention is effective as opposed to a hypothesis that the intervention is not effective. So we would have to do either experimental study designs or quasi-experimental study designs, like the before-after studies, or do observational studies like these surveillance data and looking at trends over time. But all of these require these sorts of studies. But communities don't have the resources usually to do these sorts of studies. What communities do is they do activities. And so what I'm proposing, and I'm hoping to convince you in this webinar, is to shift to a new paradigm. Instead of talking about doing our practice and our activities on evidence-based practices, and evidence-based means that you've gotten a study that has shown that it's a valuable thing to do. Can we get evidence of effectiveness from doing things? And I call that evidence of effectiveness from practice. So we can build evidence from two approaches, from qualitative evidence to complement the quantitative evidence. And qualitative one would be a lot of the indicators that the SAFE community wants us to address, like community participation and multi-sectoral collaborations. But we should use quantitative evidence from the practice of activities done by the communities to complement the evidence from studies, if there is any, from that. So we can use soft impact outcomes, and people call them soft because they're difficult to measure, but these are the impact outcomes of perceptions or knowledge, attitudes, and behaviors. We can focus on the hard results outcomes of deaths or societal impacts, or the economical results outcomes that many times we are interested in focusing on. The problem is that if we're going to do effectiveness studies, they require large numbers to be able to show effects, and require long time to be able to show effects. And we have the unique particularity in the injury field that for most of the events that we're studying, they are rare occurrences, and many communities are small, so the numbers tend to be rather small. So any individual SAFE community can show impacts on human behavior and perhaps policy, but injuries and deaths are rare enough events that only the largest of cities might be able to show an impact, and may still require a long period of time to do so. So a potential solution is to combine numbers from the same community across multiple time periods, or combine numbers from across multiple small communities. Is this possible? Many people argue that it's not, because communities have unique and different circumstances, they have different and varied interventions, and they change over time. So each community also implements a comprehensive and very complex program for the safety of all members of their communities. And they're designated by the International Safe Community Certified Center for renewable 5-year periods. So how can we work? How can we do something in this case? What study designs are possible to conduct a scientifically valid evaluation? We have to actually have been criticized. One of the processes that is well accepted in the epidemiology and medical field for evaluating the effectiveness of interventions is to combine the results of randomized controlled trials using what's called meta-analysis. There is this Cochrane collaboration that promotes these sorts of activities, and the Cochrane collaboration undertook an evaluation of the safe community model using the meta-analysis approach. However, they decided that the meta-analysis was not appropriate due to the large heterogeneity of the included studies, and they said that they found positive results, but there was no consistent relationship. So using meta-analysis was not something that is going to work to evaluate our studies or our approach. The proposal that we have is using what's called meta-regression. And meta-regression is where we treat each community's annual efforts as an experimental study and combine the data from various communities over time, accounting for the increase in variability or heterogeneity by using statistical models. And one that we use is called a multi-level regression for meta-analysis, or to make things complicated and sound weird, we call it meta-regression. So I'll very quickly mention some statistical technicalities. Those of you that may be interested in looking at more details about it can look at this publication in Translational Behavioral Medicine. We treat each community's annual experience as if it was a different experiment or study in a meta-analysis. We aggregate individual annual results observed using meta-analysis procedures. We then adjust for the correlation among the data from multiple years of the same community using what's called mixed effects models. And we finally account for increased heterogeneity of the data among communities using meta-regression, which incorporates other community-level variables. So let's look at the hypothesis that we're testing. The hypothesis that the Cochrane collaboration tried to test was the safe community designation have an effect on these communities. And so in statistics, we would have that the null hypothesis is that it has no effect, and we're trying to show that it has some effect. We chose the outcome of motor vehicle-related crashes, deaths, and hospitalizations because that is one that most communities do collect information on. But we're also interested on what are the relative effects of the various components of dynamic interventions. And this is something that the Cochrane collaboration did not attempt to do because they were not even able to address the first question. We are going to try to address both of these questions. So what we did is we combined the evidence from multiple communities and multiple time periods from each community to get the statistical power to be able to show meaningful results. Why we did that? Because there's strength and statistical power in numbers. So we did two studies. We did in 8 communities across this, the globe, from Sweden to Australia, from Sweden to New Zealand, and the US to China. And we got 8 communities, and let me just very quickly go over the results. What we did in our meta-regression was to model what was the effect of getting designated on the crashes, hospitalizations, and death rates in the communities. And what we found was that getting designated led to a reduction in the crash rates per 100,000 in these 8 communities, and led to a reduction in the hospitalization rate, and led to a very small reduction in the death rate. When we adjust for the time trend, then the reduction is slightly less, but we found that there was an important effect to getting designated. We wanted to look more at components, and we were able to do that with a second pilot study that we did in Japan. In Japan, we also asked for the same type of minimum simple data on the crashes, the deaths, and the injuries that occurred by year in several communities in Japan, and whether they were designated or not. But thanks to the collaboration with the Japan Institution for Safe Communities, we were able to get more extensive information on the various programs and interventions that they did in the various communities, from coalition building to data infrastructure building to community-based programs, media campaigns, and so forth. So we got information from 8 communities in Japan for 4 years each, and because we got 8 sets of 4 annual observations and communities are quite different, we also proposed to use our meta-analytic approach. So let me show you the results of the Japan pilot study. First of all, let's look at the effect of designation on the annual motor vehicle deaths. And these were small communities, so the number of deaths are very small. On the left side here, we have when they are not designated, and on the right side we have when they're designated. And these boxes are showing us that the middle value of deaths is pretty much the same in both when you're designated or not. So there's not really much difference. What we do notice is that there's less variability after designation. So if I plot here the trajectories or the time trends in death rates for the 8 communities over time, we see that there's, some of these communities are going up, some of them are going down. But what we really wanted to look at is how do these death rates relate to designation status. So if we include the communities that have been designated, we notice with the yellow color are the ones that the years when they're not designated, and the red is when they're designated. And there seems to be maybe a little bit of a trend. Some of these trajectories that don't have a red or yellow ones are communities that have not been designated as of yet. And these are the ones that are actually having a very high increase. When we look at our meta-regression, what we were able to show was that designation, or being designated, implied a reduction of about 1.6 deaths related to motor vehicles annually. This may seem like a very small amount, and this is a pilot study in communities that have very low death rates due to motor vehicle crashes. It also was not what we would call statistically significant. When we look at motor vehicle hospitalizations, we have now larger numbers. We also see in this, what are called box plots, that the median or middle value of hospitalization rates before designation and after designation are very similar. There's more variability before than after. But if we look at our meta-regression results, we see that being designated implies a reduction of about 82 motor vehicle hospitalization per 100,000 less. And this is quite impressive because it's also statistically significant, which means that it's likely to be a true value and not due to chance. So this showed us that being designated led to a reduction in motor vehicle related hospitalizations. But one aspect, designation is just getting named or recognized by an entity outside. But what we were interested in is what particular components of their activity are working or not. So we used the extended information we got in our meta-regression, and the results that we got were that once we take into account the types of activities that they did, we find that designation still continues to be leading to about 80 hospitalizations less per 100,000 per year. And we also find out that media campaigns are quite effective in these communities in Japan. It led to a considerably lesser number of hospitalizations per 100,000, and it's statistically significant. Education programs that were done in children were not at all effective and not statistically significant, so these would not be an important one. So it allows us to find out what components of their activities were likely to be ones that they may want to do. So I know I've taken a lot of time from you, so let me just give you some concluding remarks. That one is that methodology does exist for developing stronger collective evidence for evaluating the effectiveness of multiple community-based dynamic interventions, each using different types of somewhat similar interventions. We can do it with data that is normally collected by most communities, whether it's motor vehicle-related ones. If a community has the advantage of collecting data on fires, or burns, or whatever, and we have multiple communities that are doing that, we have shown that we can actually use that information to collectively evaluate the effectiveness of a community-based interventions, even if they are very different interventions using the meta-regression technique. This allows us to develop what I call now practice-based evidence. So evidence that is coming from the practice of the activities that are being done as one way of evaluating the safe community model. I wanted to give you some references and let you know that if you're interested in the statistical methods or want to look more into it, the first 2 papers go into that. The statistical framework that's going to be used in studies in South Africa has been submitted, and there's a manuscript in preparation for the Japanese. I'll be glad to address any questions or queries that you may have. And I wanted to thank you for listening from Chapel Hill all the way to the city of Melbourne in Australia. Thank you very much.
So we wanted to thank Shrikant for recording his presentation before he went on leave. Barbara, would you like to do the wrap-up?
Yes, thank you, Megan. So again, on behalf of the Australian Safe Communities Foundation and the Victorian Safe Communities Network, I would like to thank Dr. Andres Villavasas and Dr. Shrikant Bangdiwala for presenting to us today, and thank you to every one of you for tuning in today. Please do not forget to provide feedback to us by completing the evaluation at the end of the webinar. Please keep in touch with us and let us know the types of injury themes you might like to see covered, or if there's a project that you're working on that you might like to share or showcase in the future via these webinars. Please register and also invite your Safe Communities colleagues to register and receive the Australian Safe Communities Foundation newsletter, and also register to receive the Victorian Safe Communities Network blog and like our VSCN Facebook page, and together we can all achieve more. So till our next safety seminar, good morning, good afternoon, good evening and good night, depending on where you are in the world. Thank you. Bye-bye.